Ну що ж, шановні колеги, пропоную розпочинати наше засідання сьогодні.
Well, ladies and gentlemen, dear
Вітаю всіх на
colleagues, let us
засіданні технічного
start.
робочої
So
групи
again,
про
greetings
психічне здоров'я та
and welcome
психосоціальний
to the
підтримки.
meeting of our
В Україні на
MHPSS
феодальному рівні,
TWG.
рада
And
вас
actually,
вітати. Ми
I'm happy
сьогодні
to welcome you all
маємо
here.
дискусію,
Today
присвячену
we have a
такій
discussion
цікавій і важливій темі,
dedicated to an
як
extremely
застосування
important
принципу «не
topic,
нашкодь» у сфері психічного
like
здоров'я
the
та психосоціальних
application
потреб
of a
дітей та
do no
підлітків.
harm approach
Власне,
to the
ця тема є
education and
представлена
care for
на
children and
протидіяння обговорення,
adolescents.
ми
Basically, we
отримали
had
неодноразово від вас, і також
a
бачимо
request
постійно
for
багато
you
питань від колег
to this
у
initiative
нашому
and
координаційному чаті,
approach, and
де колеги
we could see
постійно
many
ставлять питання
comments
про
from
те,
our
як краще
colleagues
надавати
in
послуги дітям
our
та підліткам, як
chat.
краще їх
And
організовувати, питання,
basically, we
відповідно,
received many
норми
questions
щодо
about how to organize these interventions.
коректних підходів
There were many
щодо
questions about the
правових аспектів
standards,
і
then the
таке
correct
інше.
approaches, of
Тому я
course,
дуже рада, що
legal
сьогодні ми з вами
aspects.
зустрілися для
So I'm
обговорення
really
саме цієї
happy that
теми.
we could meet today to discuss this
Адже
topic.
сподіваюся, що вона
As I
стане для
hope
нас, ця
that
зустріч для нас стане такою
this
першою
meeting
у низці.
today will be
Але
the
перш
first
ніж розпочати саму нашу
in
дискусію,
the
я
first in the
хотіла
series of
зазначити
similar
про
meetings.
декілька
But
організаційних
before, I
моментів.
would like to mention
Перш за
several
все, я
technical
сподіваюся, що ви
aspects.
знаєте
First and
трансляцію
foremost, I
синхронізованого
hope
перекладу,
that we have a
і ви
simultaneous
можете
translation,
обрати одну
so
з
we can
наших
use
двох робочих мов, англійську
any
або
language,
українську,
English or Ukrainian,
для того, щоб слухати
to listen
зустріч
to our
українською
meeting.
мовою. Крім того, ми просимо вас
Also,
представитися у чаті,
please
зазначити
introduce yourself
свою
in the
організацію
chat.
та контактні
Please
дані для того, щоб
indicate
колеги
your
могли з вами
organization and your
зв'язатися і
contact
також
details so
щоб ми
that
могли
your
додати вам
colleagues
до
could
протоколу.
contact you and so that we could add
І
you
третій
to
такий
our meeting
організаційний
minutes
робочий
mailing.
момент. Це
And
те,
one
що ми
more
просимо вас
thing
не
is that
використовувати інструмент на
please
основі штучного інтелекту, який ведуть
do not
трансляції
use
зустрічі, оскільки ми ведемо свій
AI
власний протокол
for minutes
і поділимося з
because we are making
вами
our own notes.
всіма матеріалами в
And
своєму
of
кінці
course, we'll
цього
share
виступу.
all the materials after this
Тож, оскільки в
current
нас сьогодні
meeting.
дуже
So,
насичена програма з різними
since we
спікерами,
have a
будемо
pretty
сьогодні
packed agenda
рухатися між
and
різними
many
компонентами
speakers
цього
will
застосування принципу «не нашкодь»,
move
починаючи
between
від
different
загальних
components,
рамок і
starting from do
рекомендацій,
no harm
продовжуючи
approach. We
правовими
start from the
аспектами,
framework and recommendations,
застосуванням
then continue with the
принципу «не
legal
нашкодь» в
aspects,
гуманітарному реагуванні,
and then how
різними
to
психологічними
apply the do no harm
інтервенціями,
approach to the
пакетами
humanitarian
і практиками
interventions. And also we'll
організацій.
discuss
Я пропоную
different
не
kinds of
затягувати
packages
далі нашу вступну
and
частину і одразу
how
переходимо
this
до
will be
першої
done by different
презентації,
humanitarian organizations. So I
яка
will
буде
stop now and will
присвячена
switch to our
власне
first
рекомендаціям, які
presentation
були
that will be
розроблені
dedicated to the
Європейським форумом,
recommendations developed
присвячені
by the
якості послуг у сфері психічного
WHA
здоров'я, які
European
надаються
Office,
дітям
and this
та
presentation is
молоді.
dedicated to the
І для цього я
quality
хотіла
of
надати
services
слово
provided
пані
to children
Дженніфер,
and adolescents. So I
яка
would like to give
долучилася до
floor
нас
to Ms.
сьогодні
Jennifer,
з
who joined
Європейського
us
бюро ГУД
today, and she
і
represents the
представляє офіс, який займається
WHO in
якістю
Europe,
послуг.
and also she
І
represents
безпосередньо
the
працює.
unit
Дженніфер, дякую, що
dealing with the
залишилися з нами.
quality
Вам
of
слово.
services. Jennifer, over to you.
Hello, everyone. Is it over to me? Great. Thank you. Thank you very much for the introduction. I apologize as I cannot understand Ukrainian, unfortunately, and I cannot speak it either, but it's lovely to be here and to see so many people, and very excited to hear about the topic of this webinar as well. I think patient safety within child and adolescent mental health is a very important area. So really exciting to see this is happening. So I have a presentation today. Do you see my screen okay?
Yeah, I think it's currently loading. Yeah, I think it's okay.
Okay, perfect. Thank you. So I will present today for just 10 minutes, and I will just present some background information about child and youth mental health, the need to improve the quality of care and patient safety, and then some relevant WHO tools in this area. Start off with, we recently launched a report just 2 weeks ago now, which outlines all the data that we know for child and youth mental health care at the WHO European region level. So the current data really does show that mental health conditions under children and young people are increasing. We know that since the year 2010, there has been a 35.5% increase of mental health conditions for those aged 0 to 19 years old. And currently, the
Sorry,
data
I
suggests...
think the slides are not moving.
Ah.
Maybe you could restart it. Sorry for interrupting.
No, it's okay. It is still stuck on the.
Yeah, it's stuck on first slide and not full screen.
Wait, so you can see this screen maybe. Okay, let me try and.
Yeah, maybe we can go like this, maybe now,
Okay.
if you try switching.
Okay. So yeah, so the data, suggests that there is an increase in need in child and adolescent mental health over time, and currently about 1 in 5 adolescents across the region are living with a mental health condition. The data we have on service provision, and I wonder, I know that Ukraine is in a very unique context at the moment, but I wonder how situation is there. We know that 1 in 5 countries across the region are lacking governance for child and adolescent mental health. 1 in 4 lack outpatient settings, 2 in 3 lack school settings. And in general, for every 1 psychiatrist, there are 76,000 children and adolescents. So we're really seeing this kind of very high need across the region at the same time as we know that there's huge variability in services, in healthcare workers, and what support is being offered. So we really see this huge need to improve and standardize the quality of child and adolescent mental health care. In terms of patient safety, which I know this webinar is on, there's even more lack of information around patient safety for child and adolescent mental health. It's something which we have started to look into, and it's a super interesting area because there's barely anything published. The only things really published are around patient safety and inpatient services, but we know there's lots of issues around medication as well. So in response to this huge need, we have this dedicated program here in Athens, which is a collaboration between our quality of care office here and our mental health team in Copenhagen. So between Dr. João Breda and Dr. Nataliia Lazari, who some of you on this call might know, this program on quality of child and adolescent mental health care. Under this program, we work under 4 different directives. So we believe that to improve the quality of child and adolescent mental health care, we need more innovation and sharing of practices. We need to strengthen capacity for quality improvement and quality of care and provide a space for information sharing. And there's more technical products needed. And of course, we provide individual country support. So I'll start with our innovation. Within our innovation stream, we do lots of work around youth engagement. So we prioritize youth engagement within our own work stream as well. So we have a youth advisory group with 8 young members, and they have lots of activities with us. They co-develop our work stream. And I really have to say that it's really worth having their input as it makes sure our work is more relevant. And we also are developing a policy, a guidance document to support policymakers to do youth participation. We also have a big focus on capacity strengthening and information sharing. I already saw Nataliia in this call, who was at our autumn school just 2 weeks ago. So we have an autumn school. We have a second one this year where we bring together Ministry of Health nominated participants to come and learn more about quality of care and share information between themselves about child and adolescent mental health. We also have a big young researchers forum, which has over 700 young researchers in it at the moment. So if you know of any young researchers who may be interested, let us know. And we also have a focus on developing technical products. We are the first workstream in WHO to be bringing together these areas of quality of care and child and adolescent mental health, which means we're really starting from scratch. So again, if there's anything which you think would be useful to have from WHO, please do let us know. Currently, we have published our big report, which we published 2 weeks ago on the status of child and youth mental health, as well as actions to improve quality of care. We have quality standards, which I'll go into more detail in a bit later. We have published about youth engagement and our Youth Engaged for Mental Health. And we've also done some country level assessments of quality of mental health care. So one here in Greece and North Macedonia, but many more ongoing. And then we've also provided tailored country support. So we work across 11 different countries this year, but more in general, to provide tailored support for improving quality of child and adolescent mental health care. And we are here and happy to support in any way, especially for Ukraine as well. So I will deep dive now into our quality standards. So the reason why we developed quality standards is because we had a big meeting of stakeholders from across the region, and we heard there were these challenges such as inconsistency in quality of care across the region, but also within countries, long waiting times, challenges with training and regulation, services that are not always youth-friendly. And really, it was determined that quality standards would be a very helpful way to overcome this. So it was first what we did to develop the quality standards is we developed our methods, and really we prioritize our methods to be evidence-based and to involve and prioritize inputs from young people, caregivers, and providers. We wanted to make sure that the standards were achievable and aspirational, but also realistic and embedded in the views of young people and users. And we launched our quality standards earlier this year in March. And here is a QR code to the quality standards. And you can see we have 15 standards across 8 themes. And we have one theme dedicated to rights and safety in recognition of how important this area is, particularly thinking about human rights, consent, confidentiality, and also medication safety as well. But you'll see there's also other ones here. So please feel free to take a look at this. And in the development of the standards, we don't want this to be another document which just sits on the shelf. We want this really to be implemented and to be easy to use. So from the beginning, we have been thinking about the implementation, and we started off by doing a pilot. So we've been working across 4 sites to understand common barriers and facilitators. And we've heard common barriers such as limited workforce and funding, gaps between policies and quality standards. But also there were quite a few facilitators, such as there was lots of enthusiasm, where there was centralized coordination, and there was also commitment from leadership. So from these, we've been supporting the implementation across these 4 sites. And from this, we have developed some implementation resources. So we've developed a clinical audit tool to support countries to assess the quality of their services. We also have some case examples to provide inspiration. So both of these are developed. They are not yet published, but we are sharing them already. So if you would like me to share them with this group, I am very happy to do so. And we're in process of developing an implementation guidance toolkit. And we also are doing ongoing support. We're trying to develop communities of practice around this area. So we are setting up quarterly webinars. We've had 2 so far this year. And next year we will be having 4 to bring together people who are working to implement the quality standards to discuss, share learnings, and also discuss on high priority areas. So this is our ideas going forward. And again, please do let us know if there is anything else which would be useful. And particularly next year, we'll be focusing a bit more around patient safety. So let us know if anything comes from this webinar that would be of use. And yes, so thank you. That is the end of the presentation.
Дякую дуже, Дженніфер. Сподіваюся, що ви можете чути переклад.
Thank you so much. I hope you can hear the translation. Can you hear me?
Так, я питаю саме в Дженніфер, чи чути переклад.
I was asking Jennifer if
Can you hear the
Jennifer, can you hear the
translation? Are you
translation?
Sorry. Okay, I will ask my question in English. I just wanted to ask you really quickly about if you could share like one key takeaway for our audience based on these guidelines, or like one key recommendation, because we have shared right now already 5 links, I think, to different materials you mentioned. And I believe that maybe not everyone will be able to familiarize themselves because not everything is available in Ukrainian. So is there, like, if there was one key message that you would share with us, what would it be? Based on guidelines.
Thank you. I have just turned the interpretation on, so feel free to speak Ukrainian as well. That's a very tough question. One key takeaway. I think, yes, really, I think, if there is dedication to improving quality of care, then we are here to support, and we're happy to help. Something which has been really helpful has been youth participation. And I've seen this make big changes in other countries and areas too. So I don't know if there's many youth participation initiatives already happening in Ukraine, but certainly I think this is something which can make a really big difference. Having young people involved in the design, the delivery, and also implementing patient experience measures as well.
Дякую велике. Дякую, це дійсно дуже корисно.
Thank you. extremely helpful aspect. It would be extremely helpful to different kind of providers. They could be engaged in the development, implementation, evaluation of services provided to different groups of clients, patients. So we would really like to reinforce this message and thank you for this. And also thank for the engagement, for your engagement and for this extremely interesting presentation. So colleagues, if you have more questions, please, we will be happy to coordinate and share the responses. So please contact me and Jennifer. So now, moving on, we'll have one more extremely fundamental presentation, and we prepared our meeting based on the questions from colleagues and questions in specifically Telegram channels. As for the legal support with regard to the delivery of such mental health services to children and adolescents, and what about parents and interaction between parents and children, we really tried hard to find experts in Ukraine and ask them these questions. Well, everybody recommended us contact Miss Masiak. So basically, she is a child psychiatrist and psychotherapist, and she's the executive director in a charity, and she is also the educator and expert. So Nataliia, I would like to give floor to you. Thank you so much for joining. And I know that you are engaged in many more activities. So over to you. Thanks, Katerina. After your introduction, actually, I'm a little bit ashamed of the way my presentation looks because simultaneously, I have a different training and I'm supposed to be a trainer there, a coach there. So basically, of course, the legal questions should be asked lawyers, but I will be happy to share my experience of 13 years of practice as a psychiatrist and mental health specialist. Well, of course, mental health support differs from psychiatrist support. There are different legal background for both of them, but I will be happy to share my experience. So sorry for poor shape of my presentation, especially after Jennifer's. Shame on me. But that's the Ukraine's reality, not to mention that I have no electricity right now in my house. So the question when and why children could seek help is relevant, so relevant and urgent in Ukraine. Well, when any dramatic situation with a child occurs, we realize that a child should be able to seek help independently. If there is an opportunity for a child to do this, then we would have a different situation in Ukraine. Well, why it is particularly relevant now in Ukraine? Well, first and foremost, Ukrainian children, and in my office, I can hear very often that I didn't tell anything to my mom, and my father is in the army, and my mom is very busy. I don't want to bother her. And the child has too many concerns, but they didn't want to bother their mom. So the child is alone with all their concerns and problems. If there were no legal barriers, then the children would have had an opportunity to seek help independently. They would have contacted us independently, and then we could provide them with the evidence-based and relevant interventions. So poor regulation, legal regulation right now. So we still have stigma as for seeking mental health services or psychiatrist services. So people don't feel comfortable seeking this help. Well, and when children share this idea with their parents, very often they may hear a negative feedback. Well, come on, you will be immediately registered. And then everybody will see you highlighted. You won't be able to find a job in the future. So this stigma is pretty high in Ukraine. And very often it is like another barrier, because if it is like a 14-year-old adolescent and they would like to seek help and parents say, no, no, we see so bright future for you, and probably will be a new like public figure or a politician. If it becomes evident, if it becomes known in the future, it will ruin your career. And then the child cannot make a decision for themselves. They have to follow their parents' opinion. One more thing. Let's talk about the context. Very often, a father could be in the army, right? And a mother could be somewhere abroad. And a child stays with the grandparents, and they could be wonderful custodians, but they have no legal background for taking care of a child, especially with this regard, with these MHPSS services. And this is another challenge. So if you look at the law of Ukraine on psychiatrist support, and the child could be hospitalized only with concern of both parents. Imagine the situation when the father is in the front line and the mother is somewhere abroad. How can we regulate the situation? Well, we found some solutions, but we understand that the child needs to be hospitalized here and now. And unfortunately, we cannot get these signatures of both parents. And this is a big challenge right now. And one more thing. This is basically from the child's perspective. We can see that like the self-regulation for a child, self-harm. So this behavioral pattern becomes younger. Unfortunately, people harm themselves being under 10. That's what they use to balance themselves, and they cannot show it to their parents, even if the parents are nearby. It is easier for them to talk to a psychologist or a mental health specialist. They show their vulnerability easily in this case, but not to the parents. The parents could reprimand them, could become angry with them. So, but if the child has first to talk about that at home, children cannot overcome this barrier. So then they do not talk about that at all. Like in 9 of 10 cases, when children come and you try to provide some support to a child, and then you ask them, can you now tell your parents about that? Sometimes it doesn't happen. So the question is about this independent referral, a self-referral to a psychologist, without necessarily telling the parents. So a couple of more things about some legal aspects. So I would like to show you the legal framework. I believe many of you who are working in the field of psychiatry and mental health, you know the law about the right to health care, and it includes also the medical help, the medical aid, and also mental health support. Also, we have the Family Code of Ukraine, the law of Ukraine on the protection of childhood, the law on the operation of psychiatrist, and also we have the law on psychiatrist help. This is our textbook that we use. So we also can have several categories of children. So a child under 14. Psychological support can be provided with a written consent of one of the parents. What about the school? At school, it's just like general consent when child enters the school, and also additional consent if individual sessions are needed. As for the psychiatrist care in a healthcare facility, in this case, both parents should provide their consent if it's a child under 14. if there is no consent of parents, and very often the child could be a victim to a battle between a parent, a mother and a father, between two parents during a divorce. For example, if one of the parents would like to prove something to the ex-partner, then the child cannot get both consents. Okay, so a minor between 14 and 18. So basically, they can seek help on their own, but many facilities require parents' consent. Outpatient psychiatrist care from 14 years old. So they can seek help independently, but if it's an inpatient care, then we should have adolescents and parents consent. And for some reasons, the child or an adolescent cannot provide this consent. So in this case, we ask for this consent from both parents. Well, basically, if how to make a child to sign this informed consent form, we need a different webinar for that. And also the full-aged person, like full capacity. The young people can make their own decisions here. As for the practices of providing care, well, cases and exceptions, special cases and exceptions, can we provide care to a child without parental consent? Under 14 years, no. At least one of the parents should provide consent. Children, adolescents between 14 and 18, there is no legal ban, but in real life, many facilities require parental consent. There is only one exception: emergency emergency mental health support. It can be provided without parental consent when the situation is life-threatening, or that the situation threatens the health of a child. We need to take care of this child here and now. So if the child is suicidal, we do not wait for any consents. We immediately intervene, as this is the emergency mental health care. It helps us to work. Well, basically, if it's offline or online support, we still need the consent. So if a child doesn't have parents, then in this case, the legal representative could be the custodian or the head of the facility where child stays. So basically, that's how we obtain the consent. That's just in brief. Well, as for the problems and challenges, there are plenty of them, and why they are extremely relevant right now, please choose any reason from the very long list. And Jennifer mentioned the WHO Autumn School, and the one 2 weeks ago in Athens, and we had wonderful colleagues that presented the Serbian experience. Like, starting from 15, children can make their own decisions, but they also have many challenges, because if an adolescent can fully be responsible for all medical interventions provided to them, it could lead to some other challenges. It's regulated there, but to say that everyone can help, no. There are different risk factors that should be considered, especially when you plan some legal changes. Katerina, that's all in brief. Thank you. Thank you, Nataliia. Yes, that was pretty brief, but very informative. I hope that we were able to answer many of questions from our colleagues. And I don't see any new questions in the chat. So I know that you have to go. So please, we'll let you go. But if anyone has questions, please write them down in the chat, and we'll then forward them to our expert. Thank you so much. Colleagues, yes? Another, the legal background, the legal framework is extremely important. And of course, we'll share all the materials presented by Nataliia. And I do hope that this presentation, on the one hand, helped us to look at this problem, trying to understand why it is so critical right now. But at the same time, it helped us to find the answers to really concerning questions. Because regardless of the fact that we may say that, yes, there are some standards, that some standards could be uncomfortable and impact the work of the experts and specialists, we still have to keep them in mind. We have to follow the regulations, because it's critical to follow the do no harm principle in our work. And actually, our meeting is all about it. So that's why today we are discussing this principle, and we look at it from different perspectives. On the one hand, we have the standards of how the services should be provided. That's what was mentioned by Jennifer. On the other hand, we have legal background, legal framework as for the parents concerned, as for the care delivered to children and adolescents, and we also have to follow them because they are binding for us. Because all those standards have their own grounds. So moving away slightly towards the humanitarian aspect of work, which is more related to the cluster system. So I would like to give floor to the team, to the humanitarian response team. And I would like to give floor to the lead of this team, Ismail, to present key principles of do no harm approach that should be followed and that are recommended by the team. So it used to be called subcluster, now it's called AUR. So Ismail, if you're with us, please, over to you.
Thank you very much, Katrina. And thank you all for inviting me here and for Child Protection AOR to contribute today to this meeting. And I know, I understand from Irina and Katrina that most of you are very familiar, experienced child protection, MHPSS practitioners. So instead of revisiting MHPSS basics for children, I'll focus specifically on how we ensure that all MHPSS provided to children in Ukraine in safe, ethical, and aligned with do no harm and safeguarding principle. If you can go to the next slide, please. So the next slide is about the global framework guiding safe MHPSS, which will anchor our discussion. These global frameworks provide the safe guiding backbone of child-focused MHPSS. And you can see the World Health Organization from UNICEF. We have the ISAC guideline for MHPSS in emergency. But for me, I'm going to maybe put more emphasis on the child protection minimum standards, 10, which tell us that safe MHPSS should look in emergency, how it should look like in emergency, which is non-intrusive, age-appropriate, right-based, and free of practices that may re-traumatize or endanger a child. And of course, as you know, also the IS layered system prevent two major do no harm risks. And this is intervention by unqualified staff and under support where high-risk children never reach specialized area. So, and also you can see the UNICEF framework. Please, next slide. I think we have 7 minutes, so I'll be rushing through most of them, and I think we will share this presentation with you later. So, in Ukraine, these global standards aren't just referenced, but they are operationalized by the Child Protection AOR. And one of them is the case management operational guidance, which is our SOP. And it also has an MHPSS annex, which establishes clear safeguarding boundaries. And that is who can provide what type of support, where the limits of non-specialized actors are, and how to make a safe, ethical referral. It is also supported by our DPISP, which is the Data Protection Information Sharing Protocol, which is a core safeguarding tool, which protects children from harm caused by mishandling highly sensitive information, something that can expose a child to retaliation or even violence. We also have trainings and referral pathways, as well as coordination with other clusters like education, health, GBV, and this, so that every child receive predictable, safe support regardless of the entry point. Next slide, please. So the next slide, so how can emergencies impact mental health and psychosocial functioning of children? And I think from the onset of the war in Ukraine, we all know that children in humanitarian action or in emergencies face multiple layers of distress. This can be trauma, displacement, fear from airstrikes, disruption of routine, and loss of safety as well. And if we do not respond in a safeguarding informed way, these vulnerabilities can be worsened. For example, asking intrusive or trauma-focused question. So understanding these stressors help us approach children gently, minimize triggers, and stabilize before exploring anything deeper. So next slide, please. So I think most of you are familiar with this, and I'm not going to take a lot of time here, but this pyramid itself is a do no harm mechanism. So by matching the level of support to the child needs, we prevent two harmful scenarios. That is, escalating a child too quickly to specialized care that they do not need, or number two is leaving high-risk children at the wrong level, where the needs remain unmet. So this layered structure protects children by ensuring appropriate, safe, and proportionate support. Next slide, please. And this slide is mostly about the ecological approach that's used by our partners all globally, but also in Ukraine. And of course, the safeguarding approach requires us to look beyond the child and consider the risk at every level around them. That's the safety net, which is either family, community, society, or social cultural norms. We can go to the next slide, please. So, of course, in case management, we have case workers, and a major safeguarding pillar is the role clarity, and each one plays a clear role. And in case management, especially child protection, case workers provide mostly the first-hand grounding, safety, and stabilization and referral. I just want to sensitize that they do not diagnose, or they do not provide therapy or other or specialized MHPSS intervention. And maybe they deal with children, but in the next slide, we want to show you that they are also caregivers in distress, and children usually absorb their parents' emotion. So when parents or caregivers are overwhelmed, children face high risk, both emotionally and behaviorally. And I think most of you as MHPSS practitioners, you are very much aware of this. And so supporting caregivers is therefore not optional, because if we don't support them, the children will be affected as well, and they will be distressed. And next slide, please. So to cover all this, we have this. We have created a module in Ukraine, and we have a capacity development focal point who deals with this, Tatiana, who is also the CPMS, our CPMS administrator. So we will kindly ask you, for all those who may be interested in these trainings, please contact her. We also have made TOTs across the country so that they can represent everywhere, and these TOTs can easily join you and assist in training, and it usually equips frontline workers with safe engagement approach to case management, as well as MHPSS. And next, and maybe I will slightly talk about the skills that is needed. Of course, these are the skills. I think this is not very new to you, so I will not go into details, but maybe I'll just peruse through. So, of course, active listening, child-centered attitude, responding with empathy, and supporting decision making. Next slide, please. And we cannot, because of the support that we usually give in the front line, we cannot talk about MHPSS or safeguarding for children without talking about PFA. And PFA, of course, remains one of the safest frontline intervention because it avoids trauma-focused exploration. And it usually focuses on stabilization and preventing emotional overload or harm to both caregivers and children. So, the next slide. Sorry. So, of course, I will go to this particular slide on safeguarding and do harm in practice. And we have this guideline, the Child Protection Case Management Operational Guidelines, and the DPISP, which is the Data Protection Information Sharing Protocol that I already talked about. And the key issue here for child protection partners is of course risk assessment at every single step of case management, informed consent and assent, explaining limit of confidentiality, safe data handling, follow-up, DPISP, which we usually make sure it is followed up strictly. And as we already told you, it's about training staff in the PFA, sexual exploitation and abuse, and also child safeguarding, and also regular supervision and staff care, because we have case managers who make sure that the caseworkers. But the most important part, and I think one of the speakers talked about this, is child participation. And we have to ensure that children have control and choices, especially, and they participate in the whole process. So maybe we just have a small recommendation for the technical working group, and this is just to enhance safeguarding across the MHPSS and child protection system across Ukraine. So we recommend, of course, strengthening the MHPSS CP referral linkages, and this of course will ensure safe referral and efficient case flow, and also promoting consistent use of PFA and child-centered approaches. And the third one is harmonizing safeguarding practices across sectors. This is something that we do every day in our cluster coordination. For those who maybe you want to join, you can check the link that has been shared by Irina in the chat. And also, one of the things that we have seen from the field is repeated assessment. And please, we urge you to avoid repeated assessment of children. We have a lot of information all over. You can reach out to us. We can give you this information. It's already done at coordination level, either with the health cluster or the child protection cluster, or the GBV AOR has already done it. So please let us avoid doing a repeated assessment of children. The most important part is, of course, we need to ensure strict adherence to the data protection information sharing protocol. And this is, of course, in line with the DPISP for child protection, also in line with the Ukrainian laws and framework. And this, of course, will reduce harm associated with data misuse. So that's all from CPAOR. Please let us know if you have any questions. This is our website on humanitarian relief humanitarian response. Please, you can access our website there and on the relief web. And we have all the benchmarks for child protection, including safeguarding. So kindly visit that page and let us know if you have any question. This was a 7-minute presentation. We had to do it very quickly. But if you have that detail, please also on the website, there's a way you can join our monthly meetings in whatever area you want, and you will be able to get more detailed information from on how to safeguard children. Thank you very much. And back to you, Katrina.
Дякую велике. Дійсно дуже важливі
Thank you so
ремарки
much
щодо
for really
проблем
important
гуманітарного
remarks.
реагування. Дякуємо, що
As for the
долучилися.
humanitarian
Бачимо,
response,
питання
thanks for joining. I can see we have a question from Ms. Irina
Прошу.
Makichak. Marina, over to you.
Добрий день, колеги.
Hello,
Я би
colleagues.
хотіла коротко
I would like
десь
to
маленький коментар і поставити
have a brief
питання.
remark and ask a
Зразу
question.
перепрошую про
Sorry
виключену камеру, тому що
for
складно зі
no
зв'язком,
camera
постійно вибиває.
because
Отож,
it's hard to ensure
питання
proper
моє
internet
наступне
connection.
питання.
So,
Ми
my
вдячні за
question
отриману
slash
інформацію,
remark. Thank you so
рекомендації.
much for
Я
the
єдине хочу
information and
нагадати,
recommendations. The
що ми
only thing that
все-таки
I
вже
would
в
like to
четвертій
remind you
Україні, і
that
вже
this is the
певний
4th year of
досвід,
war. We
який
still
зараз
we
було
already
озвучено,
have certain
рекомендації Україна
experience,
накопичила,
and
і ми
basically
можемо
some of your
потім вже
recommendations
поділитися
have already
тим,
been
що
translated
на
into the
превелике
experience in
щастя
Ukraine,
немає таких
and
ситуацій і
we're really happy for those who live in the situations with no war, no conflict, no genocide. So let's get back to reality, dear colleagues with strong expertise. Please, could you focus on a very specific area? Because, yes, there are lots of things, what needs to be done where, but the most urgent issue now is not about what, but about how. Could you please focus in your training on children's hospitals? Each region, each oblast in Ukraine has 1 or 2 children's hospitals in which, since 2025, they've organized the mental health care unit for children. This is a complex area because in Ukraine we lack children's psychiatrist or mental health specialist, especially those applying modern approaches. So as representing Minister of Health now and being an advisor to the Minister of Health, I do appreciate the efforts of your organization for the series of trainings for mental health managers and representatives of children's hospitals, because dispersing your efforts all around Ukraine or in NGOs, these are just small particles of very quality efforts, but they won't cover what we all need, what all our families and children needs. I mean, professional, well-based care. Thank you.
Thank you very much. Katrina, I can respond.
Yes, go ahead.
Okay, thank you very much. This was really a good, and I understand this is the 4th year of the response. There are some of the things that we should not be doing, and we are facing. So for us, we have over 200 partners, and usually if you look at our response, 9 out of 10 children are being reached by local partners, and actually to make sure that we reach the most important places, one of the things that currently we are doing is prioritization, the humanitarian response plan, in which we are trying to map the needs of which area are high risk and where we can respond to. Of course, the other thing is localization, to make sure that we have as many local partners as possible, and we are putting them into a leadership position to ensure that also when we transition to national partners, then they can be able to take over and run this coordination. The other thing is we try as much as possible to have our coordination hubs in multiple areas in the oblast, and make sure that these national partners are able to run them. And of course, you have talked about children in this hospital. We understand that very well, and we will try to work very closely with the health cluster. And we try also to do training for partners in other clusters to make sure that they do deal with safe referrals and safe identification of children in distress. Thank you for the comments. But in case you need more details, I have my contacts there. You can drop me an email, and I can, if there are any areas that you realize needs, then we can be able to contact our partners on the ground to make sure that they respond accordingly. And thank you for the recommendations. Back to you, Katrina.
Дякую дуже, Ісмаїле.
Дякую. Катерино, я би коротко
Thanks,
доповнила.
Katerina. Can I please quickly reflect on this? We don't need any recommendations on the local partners because we, as the central executive authority, we know them perfectly well, who is working and how on this or that territory. I would like to rechannel your focus. I mentioned what we really need right now, but of course, I use your proposal to help. Thanks, Irina. Thanks, Ismail. Yes, our platform, our TWG, and this dialogue that we have now, it reveals the diversity of our partners. And since we have the representatives of central executive authorities and different associations, NGOs, cluster system, and because of such dialogues, we could find solutions that could fit everyone and prioritize and make sure that our efforts are consistent. So as for me, these comments, these discussions are important because regardless of some disparities in approaches, I believe it is important that we are ready to cooperate and to ensure the successful implementation of do no harm approach in MHPSS, regardless of where we work, for the NGO, for the hospital, for coordination hubs, association, anywhere. So yes, these issues are critical. And trying to come closer to the content of services, of what could be provided to children and adolescents, as this is another critical issue that was raised in the very beginning of the war. I would like to give floor to our colleagues from UNICEF so that they could tell us more about the first lessons learned after the implementation of the EASE intervention that was available back in late 2023. And there were a couple of pilots in Ukraine. So to share some preliminary results and experience, I would like to give floor to our colleagues from UNICEF. Please, over to you.
Hello. Hello, everyone. Can you hear me?
Yes.
Yes. Okay. I'm just wondering how to share my screen. Apologies, because I'm using more the Teams than the Zoom. Oh, yeah, I see here. Okay. Just give me a second, and then you can tell me if you see my screen.
Так видно. Yes, we can see it.
Yeah.
Yeah.
Okay. So, and again, it will be since the time is quite limited, I do believe that there might be other opportunities to discuss about EASE. I will work through very quickly, so don't hesitate if at the end you have a few questions. I'm aware this might not answer all your questions, and this would be just an introduction. So, what is EASE first? And some of you, or many of you, might already know what is EASE. So just quickly to summarize, this is a WHO/UNICEF evidence-based intervention of level 3, which is focus, but non-specialized, can be given by non-specialist workers. It's aiming at targeting adolescents between 10 and 15 years old who experience internalizing issues such as stress, anxiety, and depression. Okay, and it consists of 10 group session, 7 for the adolescents, and 3 for their caregivers, because the methodology works for adolescents and the caregivers. Why EASE is so important? Because we know that it works. There has been 2 fully randomized controlled trial in Jordan and Pakistan, and those RCT found that the intervention EASE really reduce internalizing symptoms in adolescents. For other outcomes, they had mixed feeling. This is why we say that EASE is suitable for adolescents from 10 to 15 years old, ideally with their caregivers, but those adolescents are those experiencing significant internalizing symptoms, stress, depression, and anxiety. It's not for any mental health problem in adolescents, okay? And those internalizing symptoms are assessed by a professional tool in Ukraine, with discussion among a professional. We proposed the SDQ-25 to assess the mental health of the adolescents, and we proposed the caregiver tool MHI, which is the mental health assessment inventory. EASE is not suitable for adolescents who are at risk of self-harm, of suicide, who have severe mental health issues, who have aggressive behavior, who could disrupt the group, or who display some issues, impairment related to mental, neurological, or substance use disorder, because that could disrupt the group dynamics. So, very briefly again, the 7 sessions that are targeting the adolescents aim really at improving the adolescents identifying themselves, their feeling, improving the adolescents in managing their stress, increasing their behavioral activation, use problem-solving technique, and for this there are several easy tools to be used. For the caregivers, there are 3 sessions for the caregivers, and they will aim to improve the caregiver listening skills, to better understand their own feelings and the feelings of their children, to spend more quality time, to give more praise to their children, and to use self-care strategies. And as you will see, if some of you already know, in terms of material, this is a very structured intervention. You have the helper manual, you have an adolescent workbook, you have a storybook, you have posters, and you have handouts for caregivers. Everything is there. So for UNICEF, we have started some piloting, and I will give the word to my colleague, Katarina, who will briefly describe what we've been doing since the end of last year, 2024. Katarina, over to you for this slide.
Thank you so much, dear colleagues. Hello, and just briefly, what happened as for the implementation in Ukraine. And in December 2024, we trained 20 helpers from different NGOs, from different sectors, like the representatives of healthcare facilities, NGOs, educational facilities, who joined the training and completed them as facilitators who could do group sessions with parents and children. And after that, the facilitators also conducted 1 session for adolescents and their parents. So they tried the intervention, trying to see if it is efficient. At that time, unfortunately, we didn't do the pre and post training or session evaluation. So we used the supervision approach to evaluate the efficiency of its implementation and to get feedback. And so we also had the supervision sessions led by the trainers from Zurich University. And also we tried to develop the program that could be relevant for Ukraine's experience. And in October, December 2025, we proposed several activities. Of those 20 people, we selected those. Well, some of them conducted one group, others conducted more groups, and some of them also were ready to join TOTs. So of those 20 helpers, we trained 5 national trainers who later trained the next cohort of facilitators, and we selected 30 participants, next participants. And this time, we selected them in Odessa, Mykolaiv, Kherson Oblast. And right now we are implementing EASE, followed by piloting. And we currently use the assessment approaches already mentioned, like SDQ-25 and MHAI, to measure the impact on our beneficiaries. And basically each participant, each helper is expected to conduct one group for adolescents, between 6 to 12 participants. And at the end of the year, we hope to see the results of this implementation. And these facilitators are supervised by national and international supervisors who provide support and help with the piloting. Thanks. That's all in brief. And the key results, I believe we'll see in early 2026.
And I think you're muted.
We can hear you.
And you are mute.
And
can you hear us?
And unmute yourself.
Apologies, I was muted. So as my colleague Katya said, the person who are delivering EASE to the group of adolescents are what we call EASE helpers, facilitators. In the global tools, there were criteria to define them. We further refined them to suit Ukraine context. As you see, those EASE helpers, they can be non-specialists. Obviously, if they're specialists, it is good also, but they can be non-specialists, teachers, social workers. They should have at least 2 years experience, 2 prior experience working with adolescents, particularly conducting MHPSS activities. They should know about safe identification and referral pathway to ensure safeguarding, as we mentioned before. They should have and demonstrate competencies in foundational helping skills, and they should obviously be deemed to work with young people. So in terms, and I'm sorry, I have to get out of the show mode because it seems there's an issue with the slideshow. For the trainers, those are required to become a trainer. You would need to be qualified in a mental health field, psychology, psychiatry, etc., and have at least 5 years experience working in mental health, with at least 2 years experience working with adolescents, and working in humanitarian setting with vulnerable communities, and an experience delivering either EASE or other cognitive behavioral therapy, because we want to make sure that the trainers are really fit to accompany the helpers. So here you will see that this is what I'm not going to go much in detail. First, the helper attends a 10-day training. Then he gets to practice with groups of adolescents, those 10 sessions. Then if the helper wants to become a trainer, he attends an additional one-day training and then facilitates a training together with an experienced trainer. And obviously, as I mentioned here, anyone being trained on EASE should also have the skills on child safeguarding, safe identification and referral, and foundational helping skill from equipped. And as just a last mention, My colleague Katya mentioned, and I mentioned myself, that to identify the children with internalizing problems that are suitable to be enrolled in EASE, we use the SDQ-25, and also we monitor if there is no suicide or self-harm risk. And for the caregiver, we use a tool that is called MHI. During the implementation, we are going to collect a lot of demographic data, attendance or implementation data, as well as satisfaction. Apologies. Then all the material is obviously available on the WHO website. You have the global EASE toolkit, but we have for our pilot and our first implementation period, we have translated a lot of those tools, and we have added also, as we were saying, the assessment tool, and we are putting together a toolkit for Ukraine that will be readily available soon for anyone who would like to start using EASE. And we hope that by January, we will have the data. As my colleague said, we will measure the impact of those adolescents using those tools. We will gather lessons learned and share with you so that the whole community can learn more about how EASE is being used in Ukraine, how safe is it, the impact it has on the adolescents and their caregivers. This is all for me. Thank you very much, and let us know if you have any question. Thank you.
Дякую дуже.
Thank you so much.
Пані Ан, пані
Thank you so much, Anne. Thank you so much,
Бачу
Katerina.
питання,
I can see we have a
також
question
від Самха. Самха,
from
вам
Sameh. Over to you.
Yeah, hello everybody, and sorry that I have this repeated question every time we have EASE discussion. But because it's related to the topic of today, it's related to the do no harm approach. And I think this is one of the greatest questions that we had since day one of implementing EASE in Ukraine, which is what is the category of people who can implement the assessment tools? Because this is the issue with EASE, is that yes, we say that EASE should be implemented by non-specialized providers, which is true. But the question is, in Ukraine, are these non-specialized providers eligible to do these assessment tools or not? This is my question related to the pilot and how this will affect the implementation in the future. And for the second question, you can ignore it. I think it's not relevant. Thank you.
Я б пропонувала, оскільки в нас зараз багато ще піднятих рук, можливо,
Since we have many raised hands, maybe first we'll listen to all the questions and then we'll make brief answer session, because we have one more expert here to present, so we have only 20 minutes to the end of our session, our meeting. So let's listen to questions from Irina and Olena, and then we'll provide answers. Sameh, we heard your question about the application of this EASE assessment tool. Olena, over to you. Hi, colleagues. I'm very much interested in this intervention. So can you please tell us when is it possible to be trained to use this intervention? Thank you. And Irina, over to you. Not the question, but the remark. I've mentioned this more than once to my colleagues from UNICEF and other international NGOs, and the most complex agency to communicate this issue is UNICEF. Ukraine is not Syria, Afghanistan, or Pakistan. We have a different experience, and in Ukraine, we have a well-developed network of healthcare facilities, social services, mental health centers, primary healthcare, and so on and so forth. So I don't see the logic for looking for anyone to immediately train and then trying to understand whether they are eligible to do the job or not. So I would like to bring you back to our multi-sectoral events developed many years ago together with international partners, like the roadmap of its own, where one of the fundamentals is to build the capacity of already existing institutions. So let's focus on what exists in the mental health expert environment. Thank you. Thank you, Irina. Anastasia? Hi. I represent the children homes of Ukraine, and last year 15 experts from our organizations were trained in EASE, and they practiced this year. And we have a question as for the adaptation. Are you trying to, well, I heard that, yes. Are you going to adapt this program? Will there be any changes for Ukraine and how to work with adolescents in Ukraine? Thank you. Thank you. I have a feeling that both colleagues from UNICEF and Hanna could answer the questions, so we can be a bit confused. So, Anne, Katerina, if you have answers to the questions you heard, please, you go first.
Sure. Shall I start? Okay. So thank you for the question. Regarding I'll start from the backwards, if you don't mind. So yes, the EASE program was already, and we worked with University of Zurich in the initial phase because they used EASE with Ukrainian refugees in Switzerland, and they adapted already the global tool. And we took it further and we used that. The pilot that we did in December 2024 until April with the first group showed, as Katya has shown, that it was useful, relevant for the type of issues that young people were facing in Ukraine, that it was culturally accepted, etc. So, and we are gathering more data during this first phase, this bigger implementation phase to confirm all this. So the adaptations were already made in the first pilot in December 2024, and we are using the adaptation that was done at that time. When we did the first pilot, there was no need. The feedback we had from at that time, they were all psychologists in December. And the feedback we received from the EASE helper is that there was no need of adaptation, of further adaptation that we already made, and that this was sufficient and could be used as such in Ukraine. So I hope I've answered that questions. Then to answer the question, obviously, there are already some psychologists. However, we all know that in some areas, the number of psychologists is not enough. We know that, and therefore, we cannot stop and wait. So we are building different streams and different systems at the same time. So this intervention, obviously, as we said, can be provided by psychologists or by non-psychologists. If you have a psychologist, like I think in this in the first round, in the pilot in December 2024, they were all psychologists. This time, I think most of them, I don't have the data in my head, but I think most of them are psychologists. If you are in an area like, I don't know, Ramallah in Kherson or closer to the conflict on the front line, where you don't have necessarily psychologists either who are available, who have time, etc., this intervention can fill in the gap. So we are trying also to be closer to the adolescent where there's an entry point. So it doesn't mean that we're not building the capacity of mental health centers, of resilience centers. By the way, in resilience center, the same EASE intervention can be provided in the resilience center, or it can be provided in a mobile team going closer to the front line because there's no social services or there's no health services with that type of intervention closer to the front line. So this is an intervention that allows to cover some of the gap while we increase the presence and the availability of specialized workforce. I don't think it will ever replace them. It is not the intent. And at the same time, and we know that we and many other partners, we are also supporting the specialized workforce in the health system, in the social sectors, etc. So this is complementary. For further training, well, we will take stock, and as we said, we will look at the impact, the outcome, how will it measure the impact on the adolescents and the caregivers in January. We will analyze all this and learn from this, and then we will see how we further scale up, how it is, if there's any change or adjustment be needed, and we will share, obviously, the outcome of this first initial implementation. So for now, maybe it would be for next year if there's a demand, if the outcome in the first initial period of implementation shows that everything is going all right, that we are respecting safeguarding, that we have quality in our services, etc. So 2026, let's be in touch. In terms of the use of the tool, Sameh, it's a good point. Those tools that we are proposing are tools that are currently being used in Ukraine. I have to say that I don't think there is an issue, but it's a good point, I think, to check if there is any legal document about the use of those tools that we can check. We were working with WHO on defining which tool could be used. Those are tools already used in Ukraine, but it's a fair point to say how much are they allowed by law. I can tell you that in terms of training and supervision, even if they are, as I said, most of them are psychologists, but even if they are not psychologists, they are closely monitored through weekly supervision. They are supported, etc. So I do think that in terms of quality and safeguarding, we are doing all we can to ensure that this is used adequately in terms of safety, right? In terms of legal background, so that's the point that maybe you're right. We can come back to you on this. I don't know if Katia, you have anything else that you want to add on this regard?
Так, Катерина, ви щось хотіли прокоментувати ще?
Katerina, did you want to add anything?
Чи не трохи навіть?
So,
Я думаю, що...
no,
Гаразд. Окей.
I think I won't say anything.
Дякуємо дуже,
Okay, thank you so much, Anne. And many questions. So, guys, if you have a very specific question about the tool, please contact the colleagues. And Hanna, maybe you also would like to comment on sub-team, on task team, but please be very brief because we have 2 more presentations. Well, hi everyone, Katerina, Anne, UNICEF, thank you. Oops, sorry, power outage. I hope you will be able to see me in a minute. Thanks for sharing the results. Yep, I agree with everyone. Both Anne and Katerina saying that we need the interventions targeted at adolescents, and we need it now. And in late December 2023, well, basically this intervention is going to be like 2 years old. So I would say this is a great result when we very quickly try to do something in Ukraine. But I also agree with Irina, as it is important to prioritize. And if we are talking about the areas with no specialists, no psychologists, yes, we could engage non-psychologists like social workers or those working for youth centers. But I'd say we keep arguing about this because if we look at the frontline areas, then I cannot agree with you, because the safety issues won't let us bring children and adolescents together. The adolescents won't be able to reach these group sessions. So we are waiting for the results of implementation of the second pilot. And as we would like not just to hear, but also to see the qualitative and quantitative indicators of how is impacted Ukraine, because we know that it's working and it's well evidence-based, and randomized trials prove it. But how it should be implemented, who is going to be training, who is going to be the trainer, who is going to be the facilitator, who should be prioritized for the training? If we are talking about the scaling up at the national level, because we also would like any piloted or almost every pilot intervention to be institutionalized at the mental health care level. And I believe that our collaboration is really efficient. I mean, our collaboration with UNICEF, but it is all about it. And I think that next year will tell us more. We'll see more results than in the beginning of the year with the relatively small project implemented. So Anne said that the technical package is about to be adapted, and I hope we will have a separate meeting on ease, because basically we just talked for 30 minutes about ease only. So let's move it to the platform of the task team, because there are different concepts, different contexts. We still have questions, like who's going to be trained, how they're going to be trained, who's going to do the screening, who is eligible, who's not eligible. So I hope that in early December we'll have a separate meeting where we will be able to share different findings and outcomes, and we will be able to extrapolate the global experience to Ukraine. And as a result, we will have the quality care. And we would like to have not a pilot, but a well-institutionalized and integrated intervention. Sorry, colleagues, for long remark, but I hope that I guess that my contacts could be shared with anyone interested. And if needed, we can have a different meeting, a separate meeting. Because at the general level, I understand that many organizations would like to enter Ukraine and implement EASE. But please, first contact Katerina, contact me to discuss this opportunity, because we will have a pilot. So we are talking about the pilot results and national scale up. No more pilots. Thank you so much. Sorry. Thanks, Hannah. Yes, very valid remark. And there is one more perspective, the do no harm approach. Not the intervention shouldn't harm, but also how we plan the resources is also important. The EASE is evidence-based, and it shows, it proves that it does no harm, but it's important to correctly and accurately implement it and follow the do no harm principle. And I think we have many positive results here, since we are going to use the same framework. So let's hope we carry on. And as a result, also finally, I would like to thank our colleagues from UNICEF for sharing this experience, because it's not easy to pilot this intervention when you still lack the comprehensive understanding of how it fits the system. But since it's good that we have some progress and some data that could help us understand how it fits Ukraine and where it should be implemented. So thanks everyone for this part. And we have 2 more presentations. Unfortunately, we're going beyond the schedule. We usually try to be very efficient in terms of time management, but it not always works. But the discussions get very interesting. I hope you forgive us. But today, since not often we discuss the services for children and adolescents, we would like to present one more package owned by WHO, the one that is evidence-based, which unfortunately is not being implemented at the central level, as we do not have the clear framework of where this package could be implemented and how. But we believe that this is a very important niche, and the niche is about the skills of caregivers. And this is the evidence-based package that we have. And Yulia will present it. Yulia, over to you. This is the program that was developed for children with disabilities. Many thanks, Katerina. Happy to see you all. And I will try to be brief. And sorry if you will hear some background noise. Can we get back to the very first slide? Thanks. So a few words about the package, caregiver skills training for the parents and families of children with disabilities. The parents and caregivers, they play a very important role in the well-being of children. And particularly this is true for the families with children with disabilities. And very often they lack resources to combat the challenges they face every day. So, to improve the situation, WHO, together with the parent associations, started developing this training package in 2015. And the package was developed with input from the international experts, caregivers, family representatives, after the field testing in different world regions. This package has become evidence-based. The package includes 5 documents, including practical guides and different strategies for interaction with children. I think you can see on screen, so let's move on. The purpose of the package is to build the capacity of caregivers to promote the development and well-being of children through structured game and everyday routine. So the package is based on the UN Convention for the Rights of Children, and basically every child has the right to the development and upbringing in family environment. So So the do no harm principle is central in this training package. And it does not include any stressful training, but basically the package is based on naturalistic developmental behavioral approach. And this package excludes methods based on force and humiliation of children and so on. So this package is pretty supportive. So you can see the different aspects of this package. The only thing that I would like to mention is that there is the social communication therapy based on the approach that interaction starts with the contact and relationships. So, and the child is learning not to be the right and good, but the parents learn how to be supportive for their children. And what is important here is the well-being of parents or caregivers, because it is impossible to create a positive environment for a child if adults are exhausted. So this package is for children between 2 and 9. And so basically this package is designed for children with different types of disorders. And another important thing, next slide, please. So there is, since there is no demand for diagnosis, it helps to reduce potential barriers and harm. So the key message is that if have some support needs, it's enough. And as for the UN Convention, so the support at early stages without waiting for the formal diagnosis is in the line with the best interests of a child and their right to care without being discriminated. And one of the strongest focuses of this package is that these training materials, they are designed for parents be engaged in the process. So you're not working for parents. You're not providing the services for parents. You are doing this with parents as they train parents on the daily routine. And this approach helps to develop without any unnecessary stress and burden. And it's important to mention that this is really related to the do no harm approach, as it provides really safe support. And it helps to focus on strengths rather than weaknesses of a child. So you can see a QR code on screen. You can use it and learn more about our package. If QR code doesn't work, then we can provide link in the chat. So I hope I was brief enough. Thank you so much. Thank you, Yulia. Yes, it is a particularly important package. Probably it's not that spread as is, but this tool has become available in 2022, so it's really relatively new. And as far as I know, it's been developed for 7 years. And as far as I know, in Ukraine, I can see some question. So in Ukraine, there were some attempts to implement it, or pilot or implement it, but since it's not fully translated, I mean, its final version, and since we didn't embrace this package, we still decided to present it, even if it's not available, fully available in Ukraine, because we believe that whatever is available at the global level should be also presented in Ukraine. Maybe some of our colleagues would like to implement it, because some niches could be found here as well, and it could be made consistent with the governmental plans in terms of how this intervention could be implemented, applied, especially with regard to the families with the children with the disabilities. And I think it could be applied. If any of you would be interested in it, we will be happy to discuss it with you in terms of all aspects. Hanna, would you like to comment? Yes, please. Yeah, if possible, very quickly. Yes, there are many good practices and many evidence-based tools. The problem is that all interventions, they were not invested in this. All these interventions should not fit the system, but they should be interrelated. Yes, some of them could cover some gaps. It is important to cover the gaps, but build on, because this is a long way, and it cannot be done overnight. So the intervention also lasts for 6 months. But those of you who know about steps, you know, when we use less intense intervention that could help those with low-level stress. Some interventions could be more intense, but they have to be interrelated. That's why we shouldn't look at intervention as an isolated one. We should look at each intervention, each tool, as the one that contributes to the development of the entire system. Thank you. Thanks, Hanna. Yes, totally agree. And would like to reinforce this message, since basically we do not have enough financial resources, and it is important that what we're doing should be done in a systemic way and for the benefit of Ukraine, and builds a comprehensive system. Right now we have one more presentation, and this is the last one for today, but it is important as it helps to understand how this do no harm principle could be implemented by NGOs. And while preparing for this meeting, we tried to find the NGO that provides the services in a quality manner and also follows the principle, being at the same time the local organization. Because different organizations often say that international organizations or UN family have more funds, more resources, they can implement more practices, more interventions, and they have better access to international sources. So that's why today we invited the Ukraine-based NGO, and I would like to ask Ms. Katarina Довгопол to present and share their experience, how they apply do no harm approach. Thank you, Katarina. Can someone show my slides? Because I have no electricity. So my name is Katarina, and today I would like to share the experience of my organization in the implementation of do no harm principle. So just a few words about our NGO. So Support Child NGO has been working in Ukraine since 2022, providing support to children, the families, children with the learning difficulties, teachers, psychologists, women, and other target audiences. And for 3 years, we have implemented more than 10 projects, providing critical support to more than 15,000 beneficiaries. Next slide, please. And I would like to start with a real case. So imagine, or remember, spring 2022, we are a nascent NGO. We are in a chaos. Everything is changing very rapidly, and we are trying to build our capacity. And some team members attended training, pretty serious training, with a pre-selection, with specific selection criteria. And that was the training for trainees who, in the future, would organize specific training for teachers on how to help children with traumatizing experience. So the training included several modules, and in one of the modules, we looked at the impact of trauma on children. And of course, that included sleep disorders. What kind of changes it could provoke in children? Well, some cognitive disbalance. It could impact the studies of children at school. So the trainer perfectly provided all the information. But after that, the trainer proposed several opportunities for the teachers to provide support to children with, let's say, nightmares. So one way, so the teacher should divide children in pairs and ask the pairs to share their nightmares. So they believe that the teachers should do it in the class, including the primary school teachers or the teachers of mathematics, geography, biology, whatsoever. And my face expression, I guess, was just like on the slide. And my first thought was, I hope that the teacher of my child never attended, never received the training, because I don't want the teacher to use this approach. And of course, we had more questions, but why the teacher, school teacher, should work with the nightmares of children, and why this approach is so strange? How is it supposed to work at all? And there were some other examples and exercises and cases, and I would question them in terms of do no harm approach. But that example was the most vivid. But finally, they stopped the training. We were the first and the only participants, the only group of that training, and we didn't receive any certificates. So we are not allowed to do this training. So, from our own experience, we now know how important the do no harm principle is. And as professionals in psychology, we always follow this principle, and we know how it works. with psychologists, but as an NGO, we just made our first steps, and we kept asking ourselves, how could we understand that we basically really did no harm? Next slide, please. So we were looking for the answers. So we learned and we tried to develop policies and procedures. Our first policy was a child protection policy. We didn't at that time even have the financial policy. But first we developed the child protection policy. Then we focused on needs assessment and context evaluation. We focused on evidence-based approaches. We focused on expert evaluation of programs and projects, M&E, then the evaluation of engaged experts and partners, because personally I was scared of that trainer. Then the supervision of staff, support and training. And basically, we asked for a feedback from more experienced organizations. Next slide, please. And one more life story, life case. So we apply all that. Of course, it reduces the risks, but not all of them. So I believe that it happened in 2023 or 2024. Our NGO tries to build vertical and horizontal partnerships. And during one of such attempts, when we tried to build a partnership with other Ukrainian NGOs, so that was horizontal partnership building effort, we had a not very nice case. We were working on MOU, and we were looking for some shared ideas and so on. But before signing the MOU, we first decided to implement some small events jointly. At first, basically, we had no reasons to suspect something bad in our partners. They had all official documents, all policies and procedures. So we did the search through open sources. We didn't find any bad feedback, any negative feedback. So we planned an event for families and children. It was supposed to be free of charge for the families, and all the experts agreed to be volunteers. We posted the information, we selected the participants, and we agreed upon everything. But there is always but. At first, our potential partners asked us to reschedule the event for some unforeseen circumstances that made their participation impossible. Yes, we know that anything can happen. We also are not big, and if some staff member is missing, then we have to think how to figure it out. Of course, we call all the participants, all the families. We apologized. We agreed upon the new date. Seems okay. In a while, we approach this new date, and just on the eve of the event, the potential partners call us again and explain that there are too many participants, that they won't fit the room, something else is inappropriate, although we have agreed upon this previously. So we try to propose different options, but I couldn't even imagine to hear what I heard later. So we propose different options, and then we hear the following from our partners, potential partners. We appreciate the time and efforts of our experts, so they're not going to work for free. So just call all the families and tell them that the cost of the event is such and such. So then we'll see who is really interested, and we will be able to pay our experts. And of course, it didn't concern basically our organization. Our staff members were not supposed to be paid. Of course, we terminated any partnership attempts, and we really found ourselves in a very unpleasant situation. And we were supposed to find the solutions on our own, because the families were ready, the children were ready. They were anticipating They were thrilled. And after that, of course, they were absolutely upset and frustrated. The families were upset, parents were unhappy, children were crying. We tried to explain the situation, we apologized, and then we organized the similar event. But this approach, do no harm approach, basically was very visible there. Right now, we are trying to be very particular when selecting a partner. Next slide. So I hope I was brief enough today, and I hope that our experience and our case was very illustrative in terms of how to apply the do no harm principle. And these are the materials that we use. And of course, if you like to contact us or to know more about us, these are our contact details. That's all. You can stop sharing. Thanks, Katerina. Extremely interesting and important information and experience of a relatively young organization, but you already have the experience of how to find and build partnerships. Well, unfortunately, as for me, all those guidelines can be somewhat too complex to read, to find, to translate. And I believe that the entire meeting today will help the organizations to apply the do no harm approach in their operations. Thanks, Katerina, for your presentations. And I would like also to thank all other speakers who were with us today. Thank you those who asked questions, and we'll keep you posted. And I believe that our meetings should last longer than 1.5 hours. And maybe next time we'll plan a 2-hour meeting. And the discussions will be for 2 hours and the briefings will be for 1 hour, as it usually happens. So the next meeting will occur on the 4th of December. We will have another briefing. We'll hear the reports from different stakeholders. This will be the last meeting this year. And this year we will have one more discussion. So you will be properly informed about that. Thank you for the most. Thank you those who were resilient enough to stay. I hope our discussion was interesting and all the speakers were interesting, as it seems to me. And I hope that this discussion won't be the last one dedicated to children and adolescents. If you have more ideas and proposals on what topics should be considered, because we try to build our agenda based on your priorities and on stakeholders' priorities. So please contact us. We will be happy to organize any discussion. Thank you so much. Have a nice and safe evening, and hope to see you during our next meeting. Goodbye. Goodbye, stay safe. Take care.